Well, good morning, everybody. Hope everyone's recovered from a crazy election or still ongoing election results. I think, Sally, to your point, we're all ready for it to be over. Let's just get the winner and move on, right? I think that's what's best for our country. So with that, that's my only political commentary for the day. So no more of that. But with that, I'd like to welcome Will Humble, who is the former director of the Arizona Department of Health Services and is now with the Arizona Public Health Association. I've worked with Will in the past on ambulance issues. I currently serve on another board with him related to health, provider health and wellness. And really, you know, Will's expertise in many health areas is really something that is extremely impressive, and really looking forward to hearing today's presentation that we have for everyone. I appreciate everyone taking the time to join us today and learn a little bit today as we're going to talk about the COVID-19 vaccine, where we're going, what's coming down the pike, what it's going to look like. So with that, I'll turn it over to Mr. Will Humble.
Thanks, Glenn, and thanks for the invitation. So I've got a PowerPoint on the vaccine, which is like an hour-long webinar that I've been giving. But I thought for this, I would probably just do kind of a epidemiological summary, talk a little bit about the vaccine without the PowerPoint, and then leave a lot of time for Q&A so that I'm not anticipating what you guys are, what y'all are interested in hearing about. But I found when I've done these that the Q&A part is probably the most valuable portion. So I won't rehash what happened over the summer. You all lived right through it so that you know pretty much what happened. I'll talk about like where we are right now with the virus and what I see in the next weeks and months as important decisions that could have an influence, you know, the outcome of what happens here in Arizona. So right now, you know, we're on a trajectory that if you look at the epi curve, looks a lot like early June. Now, I'm not suggesting that I think that we're going to have a run up in cases and a hospital capacity crunch like we saw throughout the month of June for two main reasons. Number one, in June, if you remember, there was no face covering ordinance at all. And so mask wearing was sporadic and rare, quite honestly. But once the local jurisdictions put the face covering ordinances in place, you started to see in many, if not most businesses, retailers, and among the public, it became more normalized to wear a mask. So that is something that's very different. I think I got knocked off.
There you go. We got you back, Will.
I'm back. Okay. That wasn't me, I don't think. Was it? All right, whatever. I won't touch anything. So if you look at the epi curve, it looks a lot like what happened in early June, but throughout the month of June, as you remember, we just went into exponential growth. And in part, that was because there was no face covering requirement whatsoever anywhere in the state. That's something that's different today than it was back in June. Another thing that's different now than in June is that as you remember, from May 15th up until July 27th, before the shutdown or the pause, I think the governor called it, in the bars, which started on, I think, June 27th, there was really guidance for bars and restaurants and nightclubs to use mitigation measures, but zero enforcement and really no compliance checks whatsoever. Now, at least, there are some compliance expectations. Those businesses needed to sign attestations with the state health department to ensure that, or to attest that they were going to stay in compliance with CDC mitigation measures. So because both mask wearing is more common now than it was in June, and because there at least is some compliance and enforcement in those crowded indoor environments where people don't wear masks, like bars and restaurants and nightclubs, I don't expect to see us end up with the kind of exponential growth that led us to using crisis standards of care in or at least authorizing crisis standards of care in July. So while things on the trajectory look quite bad with the R0, the caseloads, the increase in cases, I don't expect us to be in that kind of hospital crisis that we saw in July. Having said that, we are entering into the influenza season. There's going to be some get-togethers later on this month. My concern is that without more rigorous compliance and enforcement in those indoor crowded environments where people don't wear masks, like bars, restaurants, and nightclubs, that we're going to see a continued acceleration that puts us closer on a trajectory to maxing out our hospital capacity again. There are two interventions that I've been advocating for over the last 3 or 4 weeks, every chance I get in the media, which is A, to get the governor to implement a face covering ordinance statewide for at least the next 3 or 4 months, let's say. We'll get to the vaccine in a little bit, so that we get better compliance with the face coverings. And number two, to improve the compliance checks at the bars, restaurants, and nightclubs, those crowded indoor environments that we now know are the primary areas where this virus really really amplifies. So, and both of these things are pretty easy. The face covering, all that requires is political capital. It doesn't cost anything. It requires political cost, for the governor, but and it causes, and it will require merchants who are not used in certain parts of the state with some strident customers who don't want to wear masks, that it will cause some clerks to be in uncomfortable situations. But to me, I think that intervention is for sure worth it and a high return on investment. The second thing is that that many of the counties are not doing proactive inspections of bars, restaurants, and nightclubs. Restaurants are supposed to be at 50% capacity and operating with table service only. Same thing with bars. And while there is a complaint hotline, which I did a lot of advocacy to try to get, which is good, and there is some follow-up on those complaints, the problem is that there is not proactive compliance checks happening and enforcement. And so the compliance with the mitigation measures in those crowded indoor environments is pretty sporadic. So those are the two things that I have been pushing for in terms of advocacy. I didn't expect anything to happen before the election on the face coverings, but perhaps we will see more. Perhaps the governor will consider that now once the results are fully in. We'll see. At the Public Health Association, we're working with the Arizona Hospital and Healthcare Association on a joint letter that the ASHA is circulating to stakeholders. And I don't know. I didn't touch anything, so I don't know what happened. You can see me again, can't you? Okay. What was I going to say? So we're in the process of getting signatures to a letter that would go to the governor urging him to put in a statewide face covering mandate. And the idea is to present that sometime after the election results are known. So, so that's where we are with that. Let me transition a little bit to some of the decisions I think that are upcoming that will be really important throughout the rest of this pandemic. One is that the vaccine is on the way. And I'm really confident that vaccines, I should say plural, I'm pretty confident that we will have at least one, probably several vaccines that end up being determined as safe and effective for wide distribution. The trials for 5 of those vaccines are underway, and some of those trials actually are happening in Arizona. Those are in phase 3. So the next stage for these vaccines are for the phase 3 trial data to get submitted to the FDA at the end of phase 3. These phase 3 trials are about 30,000 participants each. That data would go to the FDA. The next step is for the FDA to put together its review panel, where they would look at that phase 3 data and look for both safety and efficacy. The good news is that the phase 2 data, the phase 2 trial data, showed very few adverse events. And so safety has been, there's no indications of any safety issues that I know of. Phase 2 went well. The other good news is that during phase 3, I think there was only, I think Johnson & Johnson had to temporarily suspend their phase 3 trial for an adverse event that happened with one of the participants in phase 3. There was, I think AstraZeneca did about a 2-week pause. So those are good signs, because it shows you that there were very few interruptions in the phase 3 trial data, suggesting that there was very few adverse events in that data set, which obviously has not been released yet. But the fact that the phase 3 trials were only suspended very temporarily and only a couple times is a really good sign. So I expect to see AstraZeneca, Moderna, the Johnson & Johnson, the Pfizer vaccine to all be submitting their phase 3 data at some point in November this month. And at that point, there's a really key critical decision that the FDA, well, number one, that the vaccine manufacturers will be making, and then also what the decisions the FDA will make. And that is the following. Because we are in a public health emergency, it's been declared by the president, there are various options at the FDA for quicker approval of medications, and vaccines are a medication. So there's 2 routes that this vaccine could take through the FDA process. Number one is the vaccine manufacturers could ask for what's called emergency use authorization. You probably have all heard what that word means, but essentially it means that there's really very limited cursory review of data before the FDA releases a drug, and in this case, a vaccine, for emergency use authorization. That would allow healthcare providers to administer the vaccine in the absence of full FDA approval. So that is a pathway that's open for these vaccine manufacturers to apply for. I don't know if the vaccine manufacturers intend to apply for emergency use authorization. I have been doing advocacy, well, my hope is that the vaccine manufacturers hold out and ask for expedited approval review of the vaccine using the phase 3 data, and not go to emergency use authorization application, but really actually apply for approval. The reason I say that is that in order for us to get the level of acceptance that I think we'll need, voluntary acceptance of the vaccine in the community, we're going to have full confidence in the safety and efficacy of the vaccine. And I think if we go for full approval, we will be in a much better position to convince the public, enough of the public, to get the vaccine. Whereas if we go to emergency use authorization, we will have to, as a public health community, concede that there has not been full, rigorous review of the data to basically attest that the vaccine is both safe and effective with proof. Whereas if it goes through the vaccine approval process, we will be able to establish and say as a community that this vaccine is safe and effective as measured by the routine, tried and true processes at the FDA. I think that's an important message to be able to use. And I think it's worth probably the 1 month that it will take, because emergency use authorization could happen almost immediately after phase 3, whereas approval might take, well, approval would usually take months, to be honest, but that's because the review committee would meet every few weeks instead of meeting, for example, every other day. So if you put additional resources and reprioritize the time of people on the FDA review committee, you could really accelerate the FDA approval and review process for the vaccines. So I'm hoping, crossing my fingers, that the vaccine manufacturers will apply for full approval and not emergency use authorization, and that the FDA will hold out and not issue emergency use authorization, and rather expedite the full approval process. So that's where we are there. I have to say, one of the things, there have been many mistakes made at the federal level, obviously, but one of the areas that I think that the administration has really excelled with is with vaccine development, and Congress, I will say too, because the Congress authorized the funds that were needed to manufacture the vaccines that are in phase 3 trial during phase 3. Maybe you all know that, but it's a very different thing. Normally, a vaccine would never be manufactured during phase 3 because it's too much financial risk for the company. I mean, they put hundreds of millions of dollars, perhaps billions of dollars into manufacturing a vaccine that they don't know will be proven to be safe and effective. That would never happen. But because the federal government, with funds authorized by Congress, HHS has signed contracts with Pfizer, AstraZeneca, Johnson & Johnson, and others, Moderna, to manufacture the vaccine during phase 3. What that means is these drug companies, these vaccine manufacturers, are actually making vaccine now. That speeds up the process a lot by actually months, perhaps even a whole year. So by taking the financial risk out of the system. So I applaud both Congress and the administration for their work at expediting the vaccine research and development, and especially the manufacture of the vaccine. That is super helpful. And by the way, and while the government has probably spent, $10 billion on these contracts, I cannot think of a better return on investment than to spend $10 billion on these vaccines in advance during phase 3, because the vaccine is what's going to help us get life back to normal and avoid some of these expensive interventions in the community. So that's where we are now. The phase 3 data is maturing as we speak. We'll look for it to be submitted in November. Hopefully there'll be an expedited review of that data that FDA will, the review committee will accelerate their schedule. Ultimately, the decision rests with the FDA commissioner on approval of vaccine. So the review committee at the FDA will make a recommendation to the commissioner, who will then make a decision about approval. Well, either emergency use authorization, hopefully not, or in my opinion, or approval of the vaccine. And so that would happen if there is a change in administration. That would happen during the transition. So Commissioner Hahn would be the person who would be making that decision using the recommendation of the FDA review committee. So that's that part of it. Let me touch on briefly some of the nuances of the vaccine, and then we could go to Q&A. So two of these vaccines are a brand new vaccine technology that uses messenger RNA as the mechanism to create the cascade in the immune system that results in production of antibodies and T cells and immunity in recipients. The thing about that is that these vaccines require a negative 70 degrees centigrade holding temperature, which is something like negative 95 Fahrenheit, super cold. Regular freezers can't hold this temperature. So those two vaccines will require some very specific cold chain holding requirements that are not normal. So for vaccinators, they are, for people that intend to be vaccinators for these mRNA vaccines, they're going to have to think through the logistics of the cold chain. That's one part of it. Another nuance to some of the mRNA vaccines is that once you open and thaw out the vaccine, that you need to use it within a few hours. And some of these vaccines come in packets of 1,000 vaccines each. And once you open the vaccine packet, you have to use it within that time frame. So for these mRNA vaccines, there's going to have to be mass vaccination clinics because you don't want to waste any of the vaccine because you're going to have to vaccinate 1,000 people very quickly. And you need to have a really strict cold chain on those vaccines. So, some of you may have been working on committees that are thinking through the logistics, because I know there's some folks from fire and EMS on here that may end up being vaccinators for this. So not that it can't be done, it's just that you need to, it's different from a normal vaccine. Not all the vaccines are that way. The chimpanzee adenovirus vaccine, which is not mRNA, obviously, that vaccine is at a normal cold chain holding temperature, et cetera. Another thing about the vaccines is that they all, I think all of them that are in phase 3 are use a recall. In other words, there's a booster shot at about 28 days. So for regular influenza, you would just give the vaccine, thank you, record it, bill it, and go. This is going to require a recall. So you're going to have to give the vaccine and then bring the person back within 28 days. Not undoable, but creates logistical issues that I know the county health departments are working with when it comes to the community members who are willing to be vaccinators for the vaccine. So I talked about, now let's touch briefly on prioritization. As it stands right now, there is no firm prioritization document either at the state of Arizona or with CDC. The National Academies of Science, Medicine, and Engineering did put out a really well thought through document, which I have put up a link onto my blog about a month of, maybe even 6 weeks ago, or maybe it was about a month ago, where they went through and made some recommendations for where to prioritize the initial doses of vaccine. I was pleased to see that phase, or I don't, they call it phase 1A. I think they call it phase 1A is what I think the top priority should be is staff, nursing assistants, healthcare workers within assisted living and skilled nursing facilities, because the virus is leaking into those facilities through staff that are in their 20s and 30s a lot of times, that are going out to clubs and restaurants and stuff, and that have community exposures. So those folks need to get vaccinated first. And you could, the way I read the NASEM document, you could interpret that as, it just says healthcare workers. I hope, in my opinion, I'd rather see the vaccine going to nursing home workers before even ICU nurses. Perhaps both could happen at the very beginning. I just think if one of the ways to prevent the influx of these critical cases into hospitals is to get a better handle on what's happening in assisted living and skilled nursing. And the way to deal with that is through the staff first, before you vaccinate the residents. That's my opinion. You can look at that document and see the rest of how the phases are, are rolled out in their document. What'll happen next is the CDC will end up coming out with some recommendations for what they believe the priority populations should be. They haven't done that yet. And once that happens, then I would expect our state health department to then, what's the right word, crosswalk Arizona's recommendations with what CDC is saying. And I would expect that our state to be in close, in terms of prioritization, close to what CDC ends up recommending. So once the prioritization is set, once the vaccine is approved, or perhaps emergency use authorization, then it will be time to deploy the vaccine for those priority populations. And like I said, I know that the counties are working with vaccinators to get the logistics ready for getting that vaccine out. And I know I've used 25 minutes, so I'm still okay. So how many people do we need to vaccinate? So let me touch on that, and then we'll open it up for Q&A. So what we need to, the best metric that I've seen looking at how transmissible this virus is that in order for us to get COVID-19 to be a sporadic illness, it will never go away completely. But what we want to do is to get to the place where it is a sporadic illness. We need to get to about 65% herd immunity. So how do we get there? Well, these are back of the envelope calculations, but let's say by the time the vaccine is ready for distribution, we've got about 15% of the public, 15% of the public that have been infected with the virus or recovered. Okay, so that, but if we need to get to 65%, you subtract 15% right off the bat for people that have been infected and recovered. Now you're to 50%. We need to get 50% more. Well, how do we get there? We need to get there with a vaccine. So how many people need to get vaccinated to get to 50%? Well, that all depends on the efficacy of the vaccine. So now we have to make some assumptions. Excuse me. Let's assume for a moment a reasonable middle of the road assumption would be that the vaccine with the booster would be 70% effective at creating an immune response that would protect a person from infection with a virus. If that's the case, then we would need to vaccinate 70% of the population, because if you do the math, you get, if it's 70% effective and you vaccinate 70% of the population, 7 times 7 is 49, right? That's 50% of the population would have herd immunity, plus the 15% that were infected with a virus or recovered. So that gives you a sense of a ballpark of where we will need to be in terms of getting Arizonans vaccinated. So if you look at Arizona, and we have 7 million people roughly in Arizona, 7 times, so we're going to have to vaccinate about 5 million of the 7 million Arizonans in order to get to herd immunity, where we would have just sporadic COVID-19. I don't expect us to get to where measles is or something like that. I expect to get to where, it's a sporadic illness. And the vaccine can do it. I'm confident that we're going to have more than one vaccine that will help us get there. So that's a forecast really of the things to come. If I put it into 2 buckets, and number one are interventions that we need right now to slow the spread of this virus so that we avoid the necessity later on of shutting down the bars, restaurants, and nightclubs again in order to save hospital capacity. And there's, as I mentioned at the top, there's some things that we could do to right now to avoid that kind of a shutdown again. And then at the same time, prepare for, for distributing the vaccine out into the community. And I covered the high points of that. So with that, we're at about 8:30, and y'all said we had about 40 minutes for this. So if you're ready for Q&A, we could do that.
Sally, we didn't really have anything else on the agenda, so I think if Will, you got a few more things to discuss. We got plenty of time right now here. We don't have to rush through at this point. And there is a question coming in. I can in the chat. Will, I don't know if you can see that. Maybe you can address that as we work through this.
Yeah, I'm going to touch it, but I don't want to shut myself off.
All right.
Seems like the COVID strain is mutating or modifying as it moves around the world. So does the vaccine they are working on allow for mutations, or will be like the flu? Good question. So the best work on that in state that I've seen is with TGen North up in Flag. It's a collaboration between NAU and TGen, and a colleague of mine, Dave Inglethaler, is a really smart guy. And by the way, when I was leaving my job at ADHS, and I knew I was going to leave, I called Dave and I'm like, dude, you got to apply for this job. You would be great as the DHS director. And he said, it's too political. He didn't want to do it. But Dave's a good guy. They've been doing research up there in Flag and have found, in fact, yes, there are several strains of the COVID-19 virus, or excuse me, the SARS-CoV-2 virus. But the encouraging thing, they have a way of mapping those mutations and mapping I'm probably saying this wrong, but the speed at which those mutations occur. And thus far, what they found is that, yes, the virus is mutating, but it's a slowly mutating virus. There's a way that they can measure the evolution of the virus. I don't know. I don't understand the ins and outs of that, but so yes, it is changing, and there are several strains. Having said that, there have not been the kind of changes that cause an antigenic shift or a major change in the protein coat, which the protein coat, those antigens on the protein coat are what the vaccine are using to create the immune response in people. So yes, they're mutate. There are different strains, so there have been mutations, but they haven't been the kind of mutations that would cause an antigenic shift. And that's what one of the things you mentioned in the box was about the influenza virus. And that's the thing about influenza is it has these radical might not be the right word, but it has these big antigenic shifts from year to year. And that is why we need two reasons why we need booster shots for vaccines. One is there is waning immunity with the vaccines, but more to the point, there are changes in the virus that happen. And that's, you could do a whole webinar on the way that happens, but it involves ducks, pigs, and humans. All three of those animals get infected with the influenza virus, and that's why those antigenic shifts happen with the influenza virus. We haven't seen that happen, anything like it, with the SARS-CoV-2 virus. So it looks like that will not be an issue. Antigenic shifts won't be an issue. However, waning immunity could be an issue. So it could be, we don't know, but it could be that the SARS-CoV-2 virus, the SARS-CoV-2 vaccines would need a booster shot every year or every couple of years. We don't know yet. But I think of the issues that are outstanding, I think it's more likely that there would be the kind of waning immunity that would require us to have this as an annual vaccine rather than antigenic shifts. Because I think if there would have been, if this virus were unstable in that way, I think we would know by now. I think that's the only one in the chat box so far. Oh, here's one from Stephanie. We have seen the anti-vaccine movement gain strength in the US over the years, seeing outbreaks of measles and mumps. What public health measures will be taken to educate the public that vaccine will be safe? So good question. That's one of the reasons I really believe that we should go for full approval of the vaccine rather than emergency use authorization, because it will allow medical practitioners, public health officials, those of you in the EMS world, healthcare workers of all stripes, to be able to definitively say that the vaccine has been rigorously tested and reviewed using a very safe approval process, and that it is both safe and effective. Now, will there end up being adverse events that happen when you vaccinate 5 million people in Arizona? Yes, there will be. And so that's why it's so important to have done your homework up front. Those adverse events will likely be temporally associated, but not causal. And that is one of the hardest things to explain to the lay public, that the difference between association, correlation, and temporal coincidence. But the best we can do, I think, is to do our homework and go through full approval first, and then have good communication messages about both safety and efficacy. I don't anticipate at the beginning that this will be a problem. I think that the demand for the vaccine, in fact, I'm certain that the demand for the vaccine at the beginning will outstrip supply. So the question that Stephanie, you just asked, I think is a question for like May of 2021, where the distribution of the vaccine is adequate, and the vaccine is then in freezers that are ready to be used, but without people willing to get that vaccine. And so how you get there is important. One of the, I still work with the U of A College of Public Health as adjunct, and I have a group of students that are working on a project right now to do community-based participatory research on their peers. So people in their 20s, to figure out what the barriers are to acceptance of the vaccine within that group, so that you can know ahead of time what those barriers are and overcome them. So I think that kind of participatory research, whether it's focus groups, et cetera, with the general public, are important research components to coming up with thoughtful strategies to get around vaccine hesitancy. But as I mentioned, if the vaccine is 70% effective, what we really need to get is to 70% vaccine acceptance in the community. It's not like measles where we have to be at 95%. It's not going to, we know that it's not as communicable as measles for sure. So 70% acceptance. So we could tolerate, I guess what I'm saying is we could tolerate, if the vaccine is 70% effective, we could tolerate 30% of the population being vaccine hesitant. But it's an issue for sure. This is not a question, but Becky says, I'm happy to hear you say that frontline workers in assisted living and SNFs should get the vaccine first. I agree with that. And I will keep saying that. Because of my former position at the health department, I still know a lot of the journalists in town. And I'm fortunate to have been in a position here at the Public Health Association where I can speak my mind without having to, what's the right word, pull punches. Because I don't need anything from the governor or the governor's office in the future. And so I'm just speaking my mind for what I think, which has given me the kind of freedom to express my opinion on things. And I am convinced that assisted living and skilled nursing staff need to get this vaccine first, along with, by the way, visitors. So I think included in that group should be designated visitors for folks within skilled nursing and assisted living. I think they have been through so much since March in those facilities with not being able to see their loved ones, many of them at the end of life, that, that's why I think the visitors to those SNFs and assisted living to as well really should be on the top of that list. So I'm glad you're on board with that. And by the way, I have not heard resistance from that. I haven't heard anybody, once you explain it, and I haven't heard anybody that push back on that. So I'm confident that this DHS Department of Health Services will put SNFs at the top. And by the way, some of the nuances of the vaccine make it so that it's possible. In other words, some of these SNF facilities have, hundreds of workers, which means that it lends itself to a mass vaccination event of staff. I mean, you have to plan, you got to get it ready. You got to get a line of folks ready, the throughput, so that you can vaccinate enough people quickly within the thaw time for the vaccine, but it's totally doable. This wasn't in the chat box, but I have heard people suggest that, well, what if people in assisted living and skilled nursing are unwilling to get the vaccine? Well, to me, the answer to that is pretty simple. It's a condition of employment. It should be a condition of employment. And I did an interview the other day with somebody who said, well, how can you force them to do that? I said, well, we tell people who work in healthcare facilities they can't smoke in the patient's room. You have to be able to, if you're going to work in a facility like that, you have to have a commitment to protecting the lives and safety of the people that you're serving. And in this case, that means getting a vaccine. That's my opinion. I think it could be done with an executive order. So there are ways, that goes back to the vaccine hesitancy question a few minutes ago. There are ways to compel vaccination. And I see a question about hospice as well. There are ways to compel vaccination. And I think that should definitely be considered, especially for those kinds of settings. I'm not suggesting that teachers, for example, need to be as a condition of employment. But if you're in a healthcare setting, I think it needs to be a condition of employment. That's just my opinion. Speaking of vaccine acceptance, I work at a senior living community and would be hesitant to jump on the first vaccine rounds without seeing clear side effects. I don't feel enough time has passed to see the long-term effects on the body. Well, so that's one of the reasons why I think it's important to go through the full phase 3 trial. We had heard earlier suggestions by people from the White House that they could suspend phase 3 to get the vaccine out before the election. Fortunately, the FDA pushed back on that. And I even heard Commissioner Hahn say that was a terrible idea and he was unwilling to do it. So that was good. The phase 3 data, I'm going to your point here. The phase 3 trial data is basically a 3-month process. So while it is true that we don't have, for example, a full year's worth of data, we do have 3 months worth of data. And one of the things that we know about vaccines is that when you have adverse events from vaccines, it's usually close to when the injection was given. So I think it's a very low risk that there would be something long-term. And to me, I look at like everything in life and especially in public health, that everything is risk benefit. And so you have to look at this vaccine in that way. So there you have it. It's going to be an interesting thing, quite honestly, when the vaccine comes out, if there are people that work in those facilities that are unwilling to accept the vaccine. And there'll be a policy decision that has to be made, ultimately about that. I'm hopeful that the right policy decision will get made and that you don't allow people that when a vaccine is available that are allowed to continue to work around people with the kinds of medical conditions that put them at high risk. Anything else?
Anything else there for Will? Scroll up here.
Okay. Well, you guys told me 40 minutes and we hit the mark. So I have a few minutes if there's any other questions.
I think there's a question here on the timeline for 2020 into 2021.
Let me go. Will you please walk through the timeline for the rest of 2020 and 2021? Are you talking about the vaccine? Yes, and the process. Okay, so I'll be concise. So we're at the end of phase 3 for most of these for these phase 3 trials. The next step is that the internal review committees with the vaccine manufacturer, let's say Pfizer, will look at that data and make a decision about whether to ask the FDA for either emergency use authorization or for approval. It's up to the vaccine manufacturer. That's the way the process works. They decide what to apply for. It's not the government that tells them anything. It's, unless it was in the contract that I don't know about that. But they will say, they'll file the application and then let's skip emergency use authorization and go to approval. So there's a committee within the FDA of independent experts that are not working for FDA, but are outside experts that meet, review the phase 3 data. Now, normally that review would go over the course of months, but I think everyone recognizes that because of the nature of this emergency, that they can't do it that normal way. And so they have a series of experts, consultants, statisticians, contracted folks that help that review committee analyze the phase 3 data. And that process would, as I mentioned, usually take weeks to months. The folks that I know that are consulting the person I know that's consulting on this I talked to, and he said that they're committed to accelerating that process. So I think you would see December being the time period where the FDA is reviewing the phase 3 data and make a recommendation to the FDA commissioner probably around New Year's. This would be, if there is a change in administration, this would be happening during the transition. But in any case, Han would still probably be there, unless he gets fired or something. It'd be there till the inauguration on the 20th. But the FDA commissioner would then make the decision about these vaccines. Now, these are all independent things. It's not just one review. So it's like they'll look at Moderna, then they'll look at AstraZeneca, then they'll look at Pfizer, then they'll look at Johnson & Johnson. So it's not just one. They'll be looking at various vaccines and making decisions about them independently. So this is a lot of work because it's not just one vaccine. They're looking at several vaccines with several different phase 3 data sets. So this is going to be a lot of work for these review committees. But if they accelerate things and put the holidays aside and all their other work, they could get out a recommendation to the commissioner about New Year's, I think. And at that point, it would be ready to go. Because if FDA makes a decision and says this is safe and effective and licenses, let's say, the Pfizer vaccine, then it's a matter of logistics, getting the vaccine out to the vaccinators, allocating those. The CDC would make those allocation decisions to the state health departments. The states would then allocate to counties, and then counties would work with the community vaccinators to start those mass vaccination clinics. So go to your timeline. I think you could start if phase 3 data is looking good, and I believe it is, because as I mentioned, they have only a couple of these things were suspended, even temporarily in phase 3. So that's a good sign for at least the safety end of things. In terms of efficacy, the phase 2 trial data would show good immune response, not just antibodies, but T cells. So, I think we're looking at a safe and effective vaccine. And I think, to answer your question, the community vaccination could start probably in January with those highest priority populations.
I have a question that got lost in the chat box.
Okay, shoot.
It feels like the U.S. is working in a silo coming up with these vaccines when this is a global issue, and there's plenty of other countries that have been working on vaccines as well. What is the international collaboration that is happening to find best practices, to be able to kind of calculate implementation protocols so that we are working with all of our resources?
Right. So there's two answers to that question. One of the answers has to do with our regulatory process in the US. So talking about just the US part of this at first, and then I'll transition to the global question. So the US there are certain requirements within the FDA CFRs, the Code of Federal Regulations for vaccine approval. So there's requirements that are in place regarding the nature of the phase 3 trials in terms of what the FDA can accept in terms of data as they look at licensing vaccines. So part of it is the nature of the vaccine trial, where it happened, and the way that the vaccine trial was conducted. So for example, a vaccine trial in Brazil might not meet the FDA standards for what is required here. Likewise, if there was a trial in the UK or Germany, it may or may not meet the requirements that FDA has for phase 3 data, which is required as you submit it for applications for approval. So some of the vaccines are going to meet those requirements and some won't. I think the Brazilian trials don't meet the standards, and so that vaccine would be, I guess you could have it go through emergency use authorization, but not through the approval process. So that's that part of the question. But there's also a larger global question about collaboration on this vaccine. And that has been a decision that's been made by the president to not participate. And there's an acronym for it, but there's a global group of entity folks that are participating in a collaboration around the vaccine. And China's involved with the Sinovac vaccine, the Western democracies in Europe, Brazil, not the United States, because we're not participating in that. But that is something that could change in January if there's a change of administration. But I want to touch on real quick an ethical question that's kind of that we should all be thinking about. I mean, so much of everything that we do in this country is United States centric, and we're always thinking of Americans first. But think about this vaccine ethically. Is it okay for us to start vaccinating very low risk people when high risk people in places like Cameroon have had absolutely no access to the vaccine? And so there's some ethical questions about vaccine distribution that need to be thought through. I think I don't know what else to say about that, but that there's very little, if any, participation in those conversations that I know of right now that's been directed by Health and Human Services or the federal government. But definitely, I think if you think about this in terms of ethics, and I have a guest lecture coming up at the university where this is the topic that we're going to talk about, is there's some ethical questions about is it okay to be vaccinating very low risk people when in fact there's others that are high risk in other countries that may never even have an access to the vaccine until 2023, unless something else is done. So, but yeah, I'm glad you asked that question because it's something that the Gates Foundation has been talking about, but it's not been a conversation, at least at the federal level here.
All right. Well, great, Will. Appreciate your time and information. Very valuable, and your insight always great to hear from you because it offers a much different perspective sometimes than what we see and hear throughout the news and other organizations or activities we're involved in. So I know this is an evolving situation, and certainly maybe at a future point as things kind of get a little bit clearer in the crystal ball, maybe, I don't know, we'll get you back on here for an update from the group. I know that there's, this committee really has a cross section of healthcare providers on it and representatives of organizations that this will have a significant impact on the go forward. So on behalf of our committee, thank you for your time today.
All right, my pleasure. Thank you. Bye.
Great, thanks, Will. All right, on also too here we have Michelle Caldwell from Senator Sinema's office. Not to put you on the spot here, but any updates from your perspective in the senator's office going on?
Well, we've been out of session for quite some time, so not a lot of legislative movement. I do know that when we come back into session, hopefully soon, with more knowledge on what the makeup is going to be in both chambers in the coming Congress, we do have a priority of we have to do another budget or continuing resolution. The budget will expire at the beginning of December again. Hopefully another coronavirus package. Again, it'll really depend on what the results of the election are, on the likelihood of that, and whether people want to work together during the lame duck session, if it is indeed a lame duck administration. So everything is just up in the air with Georgia, Pennsylvania, Arizona, Nevada, and North Carolina right now. So we won't have more information until we know what the forecast is for our government, unfortunately.
All right. Well, we look forward to some resolution here soon, so we can get our country moving forward again. I think it's important that we start to track in the right way here. A lot of work to be done, and again, appreciate the senator's office pushing through on a lot of these issues and the challenging times that we're having. So thanks for that update. Hopefully we'll have more at our next meeting. And then Sherry or Karen, any update on the dementia training class? I think there's one coming up on November 19th.
Hi, everybody.
Yes.
Karen,
ahead,
do you
Sherry.
have an update?
We do have a class November 19th at 2:00. We have another class. This will be our fourth one, I think. We're averaging about 8 to 10 people per session, and it's been pretty well received. So I'm happy to report that. I've also talked to Banner. They also have a Spanish speaking class. So that's something that we can talk about as we move forward with offering that, and then whatever else we want to do with the program. So thank you.
All right, thank you for that. As we kind of work through here, if there's any other presenters, I think the last couple of meetings we focused on having presenters come in and talk about relative topics as we've been working through in this virtual world. A lot of good information that has been passed along. So I've thoroughly enjoyed this format and having people that have a lot of knowledge relative to specific topics come in and talk to the group. So keep the ideas coming in on that. We'll continue to work forward on some of the other initiatives that we have going. And note here from Lori, there is a flu shot clinic today at Sunland Health. So if you need a flu shot, get your flu shot. I know, it's important. And then also too, I think to Will's point about the mask, and we've been emphasizing this, with our workforce, is just mask fatigue and people just trying to get complacent. It does make a difference, whether you're at work or out in public. And certainly, we're here for the long haul on that. That's not going to go away anytime soon, but it does make a difference. And you definitely can see that fatigue setting in certain places. So just keep that in the back of your mind. And with that, I'll turn it over back to Sally for any closing thoughts or anything coming up on the chamber side.
I don't really have anything, Glenn. I will say that we have a couple of new people on the call. I don't think Carrie's been on this call before. Carrie's with Ronald McDonald House, so thanks for being on the call. And then I'm not sure who Heather is, Heather in, but it's nice to see everybody. Jeff, you're on the call representing, Mark, but not Mark anymore. You want to say hi?
Hi, Jeff Bear, Copa Health, Sally, Copa
Thank
Health.
you.
I'll be so happy to tell Norm I had something to say today. That's great.
Anyway, it's nice to see everybody.
Thank you.
All right, with that, and Heather's from Mesa Public Library. So if you
There we go.
Go grab a good book to read and enjoy some time. Stay healthy, stay safe, and look forward to connecting with everybody next month.
Awesome.
Take care.
Bye, guys. Thank you.